Do your evaluations ever take you down a different path than you thought they would based on your client's symptoms? What steps did you take to get to the root cause of your client's complaints? In today's podcast, I share with you the steps that I used in three different evaluations to determine the root cause of my client's issues, as well as the techniques that I use to treat these clients.
Hello, friends. This is Lynn Schulte, and you are listening to the Birth Healing Summit podcast. We are here for meaningful conversations that will transform the way you work with pregnant and postpartum clients. Whether it is a new perspective, tool, or technique, you'll be able to implement it into your practice today. I invite you to sit back, listen with an open mind, and grab the golden nugget today's guest has to offer. Now let's get started.
Hello, everybody. Welcome to this episode. And today I wanted to share with you three initial evals that I did the other day. I thought they were all very unique and interesting. And so I just wanted to share them with you. Let me dive in here. So the first client came to me having low back pain, right hip pain. She's perimenopausal. She has three kids that are 23, 21, and 19. She's also a postpartum doula. She is leaking after she urinates, and when she coughs, she leaks as well. She's 46 years old. She birthed on her back with people supporting her legs. She pushed her babies out really fast, she reported. She did say that her second baby was occiput posterior. And when asking about her period, she said her last period was crampy, but not a lot of blood. Her periods were painful prior to having kids, but the crampiness after the kids not as severe. So what I found in her body was that her right ilium was in an outflare position. I noticed that by the position of the PSIS on that right side just felt different than the left side. And so I think she was complaining of like that pain going down the lateral side of her hips. And so I got her into side lying and did the correction for outflare that I teach. And then also she had open birthing patterns, so corrected her sacrum and then her ischium ilium rebalancing, did that. And then I found that her right uterine ligaments were tight. So broad uterosacral and round ligaments were all tight on her right side. And then the other thing, what I started off with actually first was I got drawn to her lower rib cage and her diaphragm and her liver really felt splayed out to the side as well. So it was like pushed laterally. And so I just kept noticing that, and there was a lot of tension posteriorly in the rib cage, lower rib cage, and decreased mobility right at that same level. And so I really worked on bringing liver back into position, releasing the thoracic spine in that area, releasing the crew of the diaphragm, and then rebalancing the stomach and the liver and the diaphragm and that whole area, because we know that that's a big, big part of the core activation. We've got to have that diaphragm be able to function well, and it can really get pressurized from pregnancy and depending on where that baby is. And to me, it just felt like babies were just kind of like hammering that liver off to the side. And so that really got nice and balanced. And she was just like, oh, that feels different. As she's like, oh, I can breathe easier. I'm like, yes, definitely. So, then let's see, so got worked on the diaphragm first, then went down lower and worked on the uterus bladder and then the pelvic bones. And let's see, so internally, so after I did all that external work, then I went internally and I found her bladder was tied on the left-hand side. Her cervix was actually retroflexed. So this is the second time that I'm actually finding a retroflexed uterus. And the cervix, if you feel the cervix and you follow it like back, the fundus is really firm in there. And when you can feel this angle as you kind of palpate and you go back, that angle is a flexion of the uterus. And so the fundus was flexed back. Sometimes because of that flexion, the cervix can be anywhere. So if we just have a retroverted uterus, if the fundus goes backwards, then the cervix is pushing anteriorly more into the bladder typically. But for her, the cervix was okay. I think there was some restriction more on that left side, and I released that. Yes, the cervix was to the left. So we released that, got more mobility in there, but that the flexion is still there. The retroflexion of the uterus is still there. And you can feel the bend in the uterus when you go to palpate it as you follow it backwards. So that's interesting, but there's nothing we can do about that. We cannot change a retroflexed uterus. We're not trying to. We just want to create mobility. Okay, so that's all I did was create mobility there. I did when I did my initial pelvic floor muscle assessment, the right side pelvic floor muscles were tight. And after I released the bladder and the uterus and then came back and reassessed the organs, or sorry, the pelvic floor muscles, um, the right side really wasn't letting go. And so I had her kind of tune into, not kind of, I had her tune into that area. And as she felt into it, she was like, oh, that second burst was way too fast. And I went ahead and helped her reprocess that. And then the pelvic floor muscles just relax. So it's like that tension in there is like trying to slow things down, is the sense that I got with those tissues. So we reprocessed and replayed that birth and slowed it down for her body. And then the tissues just kind of melted. And then her core really was great and automated. It wasn't fully there yet, but we talked about the importance of making sure that the core is automated with all of the activities that she's doing. And it definitely had way more ability to do so than when we started the session. So her homework was to work on core activation, pelvic floor quick flicks and holding contractions, and TA. I do end range pulsing to help strengthen the abdomen, and that can help with the core activation piece. I have my clients do just a lift their butt off of the chair or couch an inch to get that reflexive tightening of those tissues to help with that standing up. I find that that is definitely missing in a lot of postpartum clients. So that's definitely something that I like to encourage them to keep practicing at their home. So for their home exercise program. So that was my first client. So my second new eval yesterday was a gal who has 5 children. They are 18 to 10 years old, 18, 16, 14, 13, 10. She had 3 vaginal births. She had a labored C-section because the baby had a really short cord and was really pushed up against her abdomen or her diaphragm and never descended down. So they did a C-section with him, and then she was able to have a VBAC afterwards. And so she really reports that she felt like she was in survival mode for 2 years after that C-section. So to me, there was some trauma there that I want to try to check out. But she also, after, and this is funny, this poor gal got pregnant on every form of birth control. So she wanted something permanent. And so she had the Ensure springs put into her fallopian tubes, but she really feels like that her body is not liking those, that she's gained 50 pounds after their placement. She's getting migraine headaches at times. She does have Epstein-Barr that, she's been trying to detox. And in telling her story, she said that in the past month, I think she's been to the ER 3 or 4 times because she gets these episodes where her blood pressure gets really high. And she feels like she's going to pass out, a lot of pain. Sometimes it's after she eats, or while she's eating, she'll get this, like she just feels like she's going to pass out. And so she's gone to the ER 3 or 4 times. The only test that is positive is low potassium. That's the only thing that they can find for her. And so she feels like eating is causing these blood pressure spikes. She tried doing a migraine cocktail and that made it worse. she feels, if she eats too much, her stomach feels full and it feels like it's pinching something off, is what she gets heartburn a lot. And she's also said that her last baby was her biggest one and now has a rectocele, and she's uh, leaking urine occasionally, and that comes and goes. So yeah, that was a lot, right? Well, I listened to her body, and I was drawn to her heart and her stomach, or diaphragm area. And the first sense that I got is that the heart and the diaphragm, there is, and I don't know the name of the ligament, but there is a ligament that attaches the pericardial sac, the inferior part of the pericardial sac, to the top of the respiratory diaphragm. And I've seen it in the cadaver labs, and my son had this restriction in there too, and it felt like he was having a heart attack when his was restricted. But that's what I immediately got drawn to. And I helped to just release that. It was just too tight in there. And I released that. And she immediately goes, "Oh, I can breathe better now." And and then I just had her tune into her heart, because her heart just felt not happy in there. And so I'm like, "So what do you sense and feel about your heart?" And she goes, "Oh, well, when I was 1 year old, I had to have heart surgery." And I'm just like, "Oh, okay." Anytime a child under the age of 6 has any type of surgery and they get put under, the body goes into a trauma response of, "I died." That's just because under the age of 6, everything that happens to us goes directly into our subconscious mind. There's no filter. The brain doesn't have the cognitive awareness to counter what's actually happening to them and saying, "Oh, I'm just going in for surgery. They're putting me to sleep." No, to her body, it feels like the body feels like it died. And so I could feel, as I was, had my heart, hands on her heart, I could feel the rib cage getting compressed in medially around her heart as we were talking about this. And we helped, and we talked about helping that 1 year old to feel more supported, because she remembers getting ripped from her mom and her mom crying, and she's up, as that 1 year old, she's upset too. And they just didn't treat kids with the same form of respect that hopefully they're doing better today. But so that was super traumatic. The whole experience was, so we replayed that. We helped her to feel more calm and in control, and helped her to understand what was going on. And that heart and that rib cage just melted as we replayed that experience for her. And then I also found that her stomach and esophagus felt really restricted as it comes through that diaphragm. And so we worked on helping to release that. And so there was just this beautiful relaxation in her entire diaphragm, chest, rib cage area after doing that work and helping to process that surgery for her body when she was 1 year old. Then I got drawn to the C-section scar, and it was really tight on the right hand side. And we helped that. I truly believe that that baby, that fourth baby, was actually helping to bring some awareness to her body about this tension going on in this area. And that, the baby was held really high, the cord was really short, and there was no way for babe to come on out. So that's why she had to have the C-section with him. But we released the trauma of that, and we really helped to slow things down for her. We got the right side to release a little bit. The right ovary and uterine mobility was really restricted on the right hand side, so did some release work there. And then internally on the left hand side, her pelvic floor muscles were restricted. I did feel a rectocele bulge right at the opening. Her pelvic floor muscle strength was just fair at the beginning. And bilaterally, there was more tone on the right and posteriorly, and it wasn't releasing. And oh, I forgot to mention this. When she was sharing her stories of these episodes that would happen to her, where she felt like she was going to pass out or die, or her one episode, she shared that she was standing at the sink and her daughter was 10-year-old daughter was right next to her, and her husband was out weed whacking the yard. And she told her daughter to go get her husband. Well, her husband kind of came in, but he didn't do anything. He didn't support her in any way. And he just went back out and weed whacked. And then another episode where she really felt like she was going to die, he kind of she wanted him to take her to the ER, to the hospital, and he didn't. And so those lit up for me as she was telling those stories. So I knew there was something important about that. Well, as I'm working intravaginally and I'm feeling this tension in the posterior back right side of her pelvic floor muscles, so think coccygeus and the levator ani is deep in there. And they just weren't releasing. So I just asked her to tune into it, and she tears up and she just starts thinking about how her husband isn't supportive for her. And that's what that right posterior aspect of the pelvis represents, is having support from the masculine. And so I asked her, is this the first time with your husband that you haven't felt this support? And she said, no, my dad, wasn't, my mom and dad really weren't there for me as a kid. And there were a couple of limiting beliefs that we worked on and shifted. And one is that I'm about to die and no one cares. And then that shifted into I don't matter to I effing do matter. Okay. So that's sometimes you got to use those F bombs, and it's just way more. And she laughed about it because I'm like, I think you need to say it this way. And she's like, yeah, that does feel better. So I do frickin' matter. Um, and then those shifted. And there was just this huge shift on that right side. The muscles just let go, and she just kind of had this massive peace in her body afterwards. It was so cool. And then after that, her pelvic floor activation was so smooth and so flippin' strong. It was incredible, the difference. I just wish everybody here, everybody listening in, could appreciate and feel the difference in the pelvic floor muscles from the beginning of one of my sessions to the end, because they are so flippin'. This case in particular was night and day. She was just like, holy cow, that's different. And it was just so much smoother and stronger. And so I helped her to figure out how to do. I like to teach, instruct in end range pulses of the abdominal muscles to help get that automation kicked in, pelvic floor TA activation going. And then I just told her, I'm like, let's see how that unfolds. And I also just shared with her because I said, you realize that your limiting belief of I don't matter, your husband is just mirroring that to you. And so I want you to stay open and curious to see if that shifts, because we've just shifted that limiting belief to you do frickin' matter. And so I want, he may shift and he may not. And so that's up to you to decide and see how that plays out for you. Okay. Because one of two things is going to happen. He's either going to start appreciating her more and supporting her more because she's shifted the energy around, I don't matter. He's just reflecting that to her. Or it's not going to change, but now that she knows she does matter, it's going to make an interesting time for her marriage, and we'll see how it all unfolds. But I just thought that that was the most interesting session. And she just felt so completely different in her body after that session. It was way, way cool. Okay, so then my third new eval the other day was a woman in her 50s. She just turned 50 this year, and she came in complaining about stress urinary incontinence and frequency and urgency. And she was waking once at night, but had gotten up to 4 times at night. She is currently taking some medication to decrease the bladder urgency, and she said that that's helping. She's in menopause. She's had 2 vaginal births. Her second birth was over 10 pounds. Um, And she has had times in the past where her vaginal area felt heavy, but it doesn't stay. And she does have a constant urge to go. She also has history of ankle sprains as well. Um, so what I found with her as I evaluated her, I definitely found the ankles. I worked a little bit on just mobilizing the ankle bones. There's a lot of hardness in the joints of the ankles, and so I worked on releasing that. And then the biggest finding was that when I went to mobilize the uterus, it was beautiful. It moved in all planes, all directions, and the bladder did the same. However, the bladder or the uterus was stuck on the bladder. The uterus had no independent movement of the bladder on the bladder. And so that was something that we really worked on and freed that up. And I'm like, well, heck, that could be causing your frequency and your urgency because the uterus is too attached to the bladder. The bladder can't expand fully and it can't lift or move the uterus out of the way. So we freed that up externally. And then I was really curious to see what I was going to find internally on her as well. But when I had her contract and assessed her pelvic floor muscles, right when I started the intravaginal um, protocol that I teach, the assessment really only her pubococcygeus muscles were contracting. I could just feel this one band on either side that was the PC muscle. And and I did find her sacrum inflection and ischial splays, and so I corrected all that before I did intravaginal work as well. And the cervix and the bladder were restricted on the left-hand side, but I didn't find the cervix poking into the bladder like sometimes I find in some women that have urgency frequency, but that wasn't the case. But we did release any restriction between the bladder and the cervix. And, my goal when I'm assessing cervixes is to get them to be like a piñata. They need to be able to move 360 and up and down. So we worked on that. And after I did that, we got her pelvic floor muscles contracting much better, and she could really feel the difference. And like all the muscles were coming to the party. And she was just like, whoa, that feels so different. So the entire pelvic floor was coming to the party when she contracted. I had her blow up the balloon in supine, and there was no bulging down. I had her do, coughing and all that stuff, and I didn't find anything. But I did have her get up and assessed her in standing. And it was so interesting because when she went to contract in standing, she was actually bearing down. I was shocked. I was like, oh, okay. Well, and so she was pushing that urethra and that bladder down as she was contracting. So we worked on helping her to figure out how to contract back up and in, and coordinating that with her breath, and just activating that core activation in a back up and in motion versus that bearing down motion. And she was like, whoa, that's different. And then I like to bring that into functional movements of bending and standing, squatting and standing, lifting a leg. And then I remove my finger internally, and then we work on sit to stands and core activations and lifting exercises, and just helping her to appreciate that automaticity that needs to happen in that core, and making sure that it's that back up and in that she needed to change. And I said, I think that's the biggest reason why you're leaking with the stress urinary incontinence. So she had both stress urinary incontinence from the way she was activating in standing only, like laying down, she was fine. So this really hammered home to me the importance of making sure that we check people in standing, because what she did in standing was completely different than what she did laying down on her back, so in supine. So I she was just like blown away at the difference and being able to activate in a way that allows her body to feel more strong, to feel more supported. And so she's going to work on that, and I'm going to have her follow up in a couple of weeks to see how she's doing with making sure that her core is automated. And that's one thing that I've just learned over the years, is that I'm not done with my clients until I feel them automated, because if they don't get to that automation where pelvic floor and core are kicking in automatically, what happens is that when they stop doing their exercises, their symptoms come back. So please make sure that you are working with your clients to get their system, get their core automated so it happens automatically. And that's what's going to keep them strong and symptom free, when that core can automate and work in that supportive way for people. So I just thought those were really three very interesting cases that came through my clinic this week, and I wanted to share those with you. I hope you found them helpful, and please know that I would love to hear your thoughts on these case studies. I'd love to hear what you are finding in your clinics or your clients. So please stay in touch, reach out, let me know what you are sensing with things, and let me know your comments from this one. All right. Thanks everybody for listening in. We'll see y'all on the next episode. Here is to smoother births and faster recoveries. Take care, everybody. Bye-bye.
Today's podcast was brought to you by the Institute for Birth Healing. To discover more, visit instituteforbirthhealing.com. To claim $50 off of any online course, use coupon code PODCAST50 at checkout. Till next time, I'm Lynn Schulte, founder of the Institute for Birth Healing.